Good afternoon, everybody. I'm very grateful to the organizers of this international symposium for giving me the opportunity to talk to you about healthcare data in the UK. Thank you very much. It's an honor to be able to join your event. I'm sorry I can't be there in person. That's a huge regret for me, but my work commitments in UK were too pressing for me to come away for a few days. I'm also very grateful to the audience for joining me to be able to share some of the experiences from the UK with you. Thank you very much indeed. Next slide, please. So I'll start by telling you something about how healthcare data in the UK is organized because it's useful background. So the UK comprises 4 devolved administrations of England, Wales, Scotland, and Northern Ireland. They have their own governments, and health policy is largely determined locally. But that said, there are some very common features across all 4 areas. So we have universal population coverage. The healthcare system, the NHS, the National Health Service, covers the entire population in each country. The health service is funded through taxation, and it's free at the point of use for all users. So the vast bulk of the population of the UK is covered by a free national health service. Policy making is largely national at the level of the 4 countries, and implementation of healthcare delivery happens locally. We have a commissioner-provider model, which is that there are local health boards in each area, and they commission the healthcare services depending on the needs of their population. And the providers, that's the GPs and the hospitals and so on, provide the services. Because we have a national healthcare service, we have very comprehensive health data. It covers the whole population because everybody is registered with the GP. It covers all commissioners, all providers, and it covers all sectors of care. So it covers primary care, that's GPs, community care, hospitals, etc. So we have unified data flows covering the whole population, which is a very big asset in terms of healthcare data. The data is used by many different agencies nationally for producing analyses at national level, for example, the Office for National Statistics and NHS Digital. It's also used locally by commissioners and providers, and it's used by researchers. The data is used for quality improvement, it's also, a lot of it is published so that there is an accountability to the public about how their taxpayer-funded healthcare system is performing. And there's a lot of use of it for research. Next slide, please. So because we have a national healthcare service, we have very rich data for analysis. The data covers the entire population, and there's routine healthcare data flowing all the time through the system. During the pandemic, there were very rapid data developments in the healthcare system. We had a lot of new data sources coming on and new developments in record linkage across health sectors in order to be able to produce new analyses that would support control of the pandemic. I'll say more about this later. So normally, and especially so during the pandemic, we have a huge range of analytical outputs. We had daily dashboards on the number of people admitted to hospital, the number of people dying, where they were dying, and so on. There was very detailed, almost real-time data available. And because, again, it covers the entire population, we can analyze the data in many different ways, by region, by occupation, by characteristics of the people, like whether they have a disability or not. We were able to very quickly identify who are the clinically vulnerable people so that they could be vaccinated and given priority in vaccination. We're also able to link records across mortality and health data to examine inequalities in COVID-19, for example. And that data can be linked also to the census, because from the census, we have more details about the population, like what their occupation is, what their household size is. We found, for example, that households where there were larger numbers of people and older people, because some families live with parents and so on, they had a high risk of infection and dying from COVID-19. So this linkage across data sets was tremendously useful in the pandemic. We were able to analyze differences in hospital admission and mortality by socioeconomic status, by ethnic group, and so on. By vaccination status, we could measure the differences in mortality between those who've been vaccinated and those who haven't, for example. We also, at the time of the pandemic, introduced new regulations which included greater sharing of data across different agencies. So we were able to share data and also link between different health data sets. I'll give examples of that. So the analyses that we undertake in the UK of health data basically reflect health policies. So they're focused on things like reducing hospital admissions, waiting times. There's a big focus in the UK on examining inequalities in healthcare between different socioeconomic groups. We find that the affluent groups have much better health status than poorer groups. There are differences between ethnic groups. The UK has a large population of non-white people, people from South Asia and Africa and the West Indies. We're able to look at differences in healthcare patterns and use of healthcare between groups. And of course, the data was very useful during the pandemic. Thank you. Next slide, please. So I'll start by talking about primary care data. And here I'm talking about data in general practice. There are about 8,000 general GP practices across England. I'll be talking in my talk mainly about data, but there's similar health data for the other countries as well. And with the GP data, we have electronic health computer systems, electronic health records across all primary care data. And the 8,000 practices are supplied their software by just a few software companies. So all that data can be accessed very quickly and readily. With the primary care data, we don't extract the data itself. It sits in the computer systems of GPs, and we use software just simply to analyze the data that's there, so that there's no issues around anonymization and so on, because the data never actually leaves the GP computer systems. We just have software that runs queries on that data. I'll give you some examples of that. The data is, the primary care data is used for monitoring the quality of care and for quality improvement. We also have a pay-for-performance scheme for GPs, where we use a certain set of evidence-based quality measures in different disease areas, and the GPs are paid accordingly for that. And of course, the data is used for research. And this data was extremely useful during the pandemic, because we were able to analyze the data in real time to see what was happening to patients. So there's huge advantages here, because the primary care data covers all patient records. So it's virtually the entire population of the country. We have a full patient record available for any condition with all the characteristics around diagnoses, prescribing, outcomes, hospitalization, and so on. And that GP data is then linked to hospital records, to mortality records, and so on. And it's real time because the GPs are recording the patient's details as patients come in through the door, and the data can be analyzed straight away. In the pandemic, we had a new system set up called Open Safely, which was set up to try and control the pandemic, but also it was data available for researchers, for example, to look at hospitalizations, who was dying, who was in intensive care, what had they been prescribed, and then to look at things like vaccinations and so on. So it was there to enable both doctors and medics to deliver care, but it was also available for researchers. For example, and I'll give some examples later. Next slide, please. So here are some examples, and this is just a small set of examples of the sorts of indicators we use for analyzing the quality of care delivered by general practice. We have indicators on heart disease, medication, what patients are prescribed, what's their level of blood pressure control, and so on. Hypertension, data on stroke patients, on diabetes. There are lots of indicators around medication, annual checks, blood pressure, blood sugar control, and so on. COPD, cancer, mental health. We have indicators on, for example, whether people with severe mental illness like psychosis have physical health checks, because we know that people with severe mental illness are much more likely, they have a shorter life expectancy than the general population. So it's important to make sure they're having checks for cardiovascular disease, for example, diabetes, and so on. So we have indicators on that. There are pressures also to improve public health. So, our obesity being monitored in patients presenting at general practice. And similarly for smoking, are smokers who come to see their GP, are they being recommended for smoking cessation services and so on, and things like vaccination. So the GP data is a very valuable resource for us. Next slide, please. This slide, and I'm sorry, it's a little difficult to read, but it's just to give you an example. This is the data for all of the practices in an area called Blackpool, which is one of the poorest areas in England. And the population there has a much shorter life expectancy than in other areas. And down the left-hand side, you can see there's hypertension, depression, non-diabetic hypoglycemia, asthma, diabetes mellitus, obesity, chronic kidney disease, and so on. And for each condition, the blue bar shows what the prevalence of that disease is in that particular area, Blackpool. And the grey bar shows what the national average disease prevalence is. And you can see, for example, that the first blue bar, which is hypertension, almost 20% of the population in Blackpool has hypertension. And that compares with a ratio of about 14% nationally. Similarly, much higher rates of prevalence of disease for all the other conditions as well. So that's one of the examples of where data is used both at geographical level and at GP level, but this is aggregated data taken straight out of GP systems. Next slide, please. So this is one indicator. It shows blood pressure control in people under 80, those with patients with recorded hypertension in whom the blood pressure is controlled at 140, at less than 140/90. And this represents the data from almost 7,000 practices. And it shows that there's quite a range of performance from about 50% of hypertensive patients having their blood pressure controlled to over 80 in some areas. So this illustrates that there's a big variation at general practice level. And this is the sort of data that's very useful for driving quality improvement, for example. Next slide, please. So I'll say a few words now about our hospital records. I know that in South Korea, you have very rich data, and we have learned through the HCQ OECD program, we have learned a lot, heard a lot about the very rich data that you have in South Korea. In UK, we also have electronic health records for all NHS hospital patients, covering inpatients, outpatients, and A&E, that's accident and emergency patients. There's ongoing data collection, and the data is collected into national data sets, which are then cleaned. All these data sets include a unique patient ID that can be used for record linkage to mortality and also to other health records like GP records. The access to data is open, it's available to the NHS, and it's used, of course, for quality improvement and so on. The data is used for research. Having been pseudonymized, it's made available for researchers, and hospital level indicators on quality are published for the public because it's a public taxpayer system. So there's a need for accountability to the public about hospitals, of how they're performing. So we have a huge range of indicators. Next slide, please. So this is just a brief summary of the sorts of indicators we have. They'll be similar to what you do in your country. We have indicators on mortality by diagnosis and procedure. We have indicators on readmissions, again by diagnosis, procedure, length of stay, and so on. Infection rates, there was a big crackdown on hospital-acquired infections because that was a problem at one point. Waiting times are a big issue in the UK. We do have long hospital waits. And this shows how different hospitals are performing. And then the data can be analyzed both by hospital, but it can also be aggregated and look at differences between different geographical areas, different age groups, sex, different socioeconomic groups, to measure, for example, do poorer groups have equal access to hospital care, and by ethnic group. And the data is published for the public so that they can see how their local hospital is performing. Next slide, please. So this is just a funnel plot. It shows hospital level mortality. This is England, December 2019 to 2020. And you can see although most hospitals sit within the confidence limits, there are some which have exceptionally high mortality. So this sort of data can be very useful. This is routinely available for hospitals to see and inquire as to why there may be an outlier. Next slide, please. Now, this is an example. I'd mentioned earlier that inequalities is a big concern in the UK. And this shows cumulative age-standardized hospital admission rates per 100,000 population for COVID-19 in England by ethnic group. So the lowest line at the bottom, which is the red line with the dots in it, is the admission rate for COVID-19 in the white population. And above that are the admission rates for other ethnic groups, the Black groups, the Asian groups, which includes Indians, Pakistanis, Bangladeshis, and so on, and also South Asians, Chinese, and so on. And you can see that COVID-19 had a much greater impact on ethnic minorities in UK, partly because they're poorer. We were able to investigate further why this is the case. And we found that many of these groups are in frontline jobs like bus drivers, healthcare workers, and so on. So they had a much greater exposure to infection than the white population. They're also poorer. They live in higher density housing in urban areas where the transmission of COVID infections was greater. So we were able to see that ethnic minorities are at much higher risk than the white population. Next slide, please. I'd mentioned earlier that we have long waiting times in the UK, and these have become even longer during the pandemic. So this is the proportion of people who arrive at emergency departments, that's accident and emergency, we call it A&E, who have to wait more than 4 hours for either discharge or admission to a hospital bed. And you can see that in 2021-22, as a result of the pandemic, and this year, 2022-23, waiting times in emergency departments have really gone up a lot compared with previous years, and they're continuing to go up. Next slide, please. This is people waiting to start elective treatment. These are people waiting for example, hip and knee replacements or even heart surgery. And our waiting lists have gone up a great deal to almost 7 million now, mainly as a result of the pandemic. Next slide, please. We have a large program of patient experience surveys. It started many years ago in 2004, and it covers all NHS services. So we survey GP patients, outpatients, A&E patients, mental health patients, maternity and cancer patients. And most of these surveys are repeated every year. So we have very rich feedback from what patients are saying. The sample sizes are very large because they're designed to give results for every provider. The patient survey, we had almost over 700,000 people responding to the survey. So we get results for every GP practice. The last cancer patient survey was last year. We had 60,000 respondents. And the inpatient survey in 2019, there were 77,000 respondents. So we have results on patient experience for every NHS hospital. And again, these results are published. Next slide, please. So I'd mentioned earlier that the pandemic led to tremendous data developments. The electronic record systems helped. We have good legal gateways for sharing of data and record linkage, which put a lot of restrictions around privacy and so on. So there's no risk of disclosure of patient identity. We have well-established statistical routines for running queries on this data. And in the pandemic, there was a real move to try and release this data as quickly as possible. Next slide, please. Oh, could you just click it on, please? Because I think yes, thank you. So this shows the Open Safely data system. On the left in the circle is the data systems in GP practices, and the patient data sits there. It's then linked with data from hospitals and test results and so on. The data is never taken out of GP systems, so there's no risk of disclosure. But what happens is there's some analytical code that's run on some dummy data that's extracted. And those are the results that are used. So the data is never actually taken out of the GP systems. Next slide, please. Sorry, this just finishes up. So it just shows that the code is run via the analysts who supply the software for the GP systems, and there's no risk of disclosure. Next slide, please. So examples of research, we were able to show that vaccine efficacy wanes after 6 months after the second dose. We were able to analyze who is getting long COVID and what are the risk factors for COVID, the risk, what an impact UK lockdown had on hospital admissions, the risk of hospitalization from COVID-19 and death in people with disabilities, and the efficacy of antiviral and other drugs in preventing COVID adverse outcomes. Next slide, please. Can you click through so that I have the full? I think, yes, thank you. This is another public health data set that was set up. At the bottom, you can see that there's a wide range of data sets. We have the COVID-19 infection survey, which was a weekly population survey that was run, taking a random sample of the general population to monitor the level of infections. That survey is still running. So every week, we know how many people, what the level of infection is in the general population. The hospital records, all these data sets are linked back together to form a unified health record that's then linked to mortality, which is death registrations. And then on the left, the square box, the 2011 census, by linking to that, we get the other characteristics around people, like what their occupation is. That's where we found out that ethnic minorities have a higher risk of dying because they live in larger households and in urban areas, and very often in multi-generation households. So you have grandparents living with families, and the risk of exposure of infection is greater. So this is a really, really rich data set that developed during the pandemic. Next slide, please. This shows how quickly the data was turned around. This is deaths by week that ONS publishes. The blue bars show deaths from non-COVID causes. The red bars show the COVID deaths by week. And then the line shows the average for 2015-19. So you could see, you can monitor readily what's happening in relation to total mortality compared with previous years. Next slide, please. This slide shows mortality rates for COVID and non-COVID causes in deciles, that's 10% of the population, in different socioeconomic groups, the poorest being on the left, the most deprived, and on the right you have the least deprived. And if you take that as one, you can see that COVID mortality in the poorest people is 2.5 times, that's the orange bar, 2.5 times greater than in the most affluent on the right-hand side. And that's a much steeper gradient than for non-COVID mortality. That is also higher in poorer groups, but the difference between most and least is much acuter for COVID-19. So COVID-19 has worsened health inequalities. Please. So this is my final slide. It's just to say that in terms of UK health data, this is a very bird's eye view. There's a lot more I could say about it, but we have quite good, rich data systems. There are challenges because when you have large data systems, it's very difficult to change rapidly, as we had to do in the pandemic. And data protection laws can be quite difficult to work around, but we were able to do that. And of course, clinical data, even the best clinical data, has selection biases. So we need to make sure that in analyzing it, we are keeping any distortions to a minimum. But electronic health records and data linkage do provide a very rich basis for examining access to healthcare, differences in outcomes, quality of care, and so on. The pandemic accelerated and created numerous data opportunities, which we are availing of now. It facilitated new and unique analyses, and these, we hope, will support improvements in healthcare and build resilience for dealing with future emergencies. So that's a bird's eye view of healthcare system data in the UK. I hope it's of some interest to you, and I thank you all again for giving me the opportunity to present. Thank you very much indeed, and I hope you have a good function.